معالي وكيل وزارة الصحة الفلسطينية دكتور عدنان المصري، المتحدثون المتميزون، الأطباء ومديري المستشفيات والاختصاصيين والضيوف الكرام. بداية أود أن أشكر معالي وكيل وزارة الصحة الدكتور عدنان المصري عن هذه الكلمة الرائعة التي افتتح بها هذا المؤتمر. إنه من دواعي سروري أن أرحب بكم في المؤتمر الثاني لشبكة الطب الاتصالي، وأتمنى أن تتعرفوا على أهمية استخدام التطبيق من خلال الممارسة اليومية ومعرفة أهميته في تحسين القطاع الصحي في منطقة الشرق الأوسط. من دواعي سروري أيضاً أن أتحدث إليكم اليوم في لغتكم الجميلة، طبعاً اللغة العربية، تحت عنوان الطب الاتصالي تعزيز التعاون الطبي الإقليمي في الشرق الأوسط. نتأمل أن يعزز هذا المؤتمر التعاون فيما بينكم بشكل عام، وبالأخص في مجال تشخيص الحالات المرضية النادرة، بما يعود بالنفع على المرضى وعليكم أيضاً من خلال توسيع الشبكة الطبية المهنية الخاصة بكم. عقدت الGIZ بالتعاون مع وزارة الصحة الفلسطينية مؤتمراً في رام الله في تشرين الثاني 2013 بعنوان الطب الاتصالي طرق جديدة للرعاية الصحية الشاملة، حيث اجتمع 70 مشاركاً من الأراضي الفلسطينية. ونحن متحمسون لفعالية اليوم بحضور الأطباء من الأراضي الفلسطينية والأردن. كما نخطط لعقد مؤتمر ثالث في تشرين الثاني 2014. إن مشروع الطب الاتصالي هو أحد مشاريع الصندوق الإقليمي المفتوح التابع للGIZ. يعالج الصندوق الإقليمي المفتوح القضايا الاجتماعية والاقتصادية، ويركز على التعاون إبرع الحدود بين الأردن ولبنان والأراضي الفلسطينية. وتلتزم الحكومة الألمانية بتنفيذ المشاريع التي تعزز الحالة الاجتماعية والاقتصادية لسكان هذه المناطق. وبدأ مشروع الطب الاتصالي في عام 2009 بالتنسيق مع وزارة الصحة الفلسطينية. يسهل المشروع تبادل الصور الطبية بين الأطباء من خلال تطبيق مجاني وسهل الاستخدام، ويمكن الوصول إليه على شبكة الإنترنت. إن تطبيقات الطب الاتصالي بعيدة المدى ويمكنها أن تصنع ثورة في المجال الطبي ككل. التركيز الرئيسي للمشروع هو تشجيع الأطباء للتشاور فيما بينهم، وخصوصاً في تشخيص الحالات النادرة، للتقليل من التشخيص الخاطئ، ولتوفير الوقت والجهد في نقل المرضى. الطب الاتصالي هو حق الواسع يشمل التقييم والتعليم الإلكتروني عن بعد والتشاور والتركيز على الاستشارات عن بعد. وقد حقق في هذا السنة الماضية المشروع نجاحات وتغيرات إيجابية عديدة، وقد نقل تركيز المشروع عن الأمور التقنية إلى تركيز أكثر على بناء الثقة وتوسيع الشبكة. واحدة من أهم إنجازات هذا العام هو إنشاء اللجنة التوجيهية بالتعاون مع وزارة الصحة الفلسطينية، ومن أعضاء اللجنة معالي وكيل وزارة الصحة الدكتور عدنان المصري، وهو رئيس اللجنة التوجيهية. اللجنة هي الهيئة الرئيسية لاتخاذ القرارات للشبكة. إضافة إلى ذلك هي وسيلة لضمان استدامة الشبكة عند انتهاء تولي GIZ إدارة الشبكة في آذار عام 2015. ومن بين الأنشطة الأخرى التي حدثت هذا العام كانت تثبيت جيتويز في مستشفيين فلسطينيين، والتي تعتبر وسائل تسرع تحميل الصور الطبية. كما تم تدريب المتخصصين في مجال تكنولوجيا المعلومات من وزارة الصحة من أجل أن يكونوا قادرين تماماً على التعامل مع الأجهزة وبرامج المثبتة حديثاً. الرؤية لهذا المشروع هي في نهاية المطاف تجميع الأطباء من دول الجوار وتعزيز التعاون الإقليمي الطبي بين الأردن والأراضي الفلسطينية. لذلك تم القيام بزيارات الأطباء في عمان لا تشمل الأطباء من مركز الملك حسين للسرطان ومستشفى الحياة ومستشفى التخصصي ومستشفى الإسراء ومستشفى الجامعة الأردنية ومستشفى الأردن. نتمنى أن يوفر هذا المؤتمر فرصة فريدة للأطباء للقاء وتوسيع الشبكة المهنية لهم. نحن نحاول أيضاً التعريف بالأطباء الفلسطينيين من الخارج لا يصبحوا استشاريين في الشبكة، بما إنه يمكن الوصول للتطبيق من أي نقطة في العالم. GIZ تلتزم بضمان استدامة مشاريعها، ولذلك تم تدريب موظفي قسم تكنولوجيا المعلومات من وزارة الصحة على كيفية تشغيل التطبيق، وكذلك أصبحوا مدربين لأي عضو جديد ينضم للشبكة. ويتم تدريب الأطباء الذين يسجلون في النظام ويطلب منهم تبادل ملاحظاتهم لتحسين التطبيق. ونحن حالياً في السنة الرابعة من عمر المشروع، ونعمل أن تختم أنشطتنا في شهر آذار من عام 2015. سوف نبحث في تقييم المشروع في الأشهر القليلة المقبلة لتحديد حجم مشاركتنا في المستقبل، حيث أن اللجنة التوجيهية تشارك بشدة في تقييم العمل وتقديم التوصيات لضمان أقصى قدر من التأثير في مجال الطب الاتصالي في الأراضي الفلسطينية والأردن وخارجها. اليوم سوف لن نركز فقط على المشروع كجزء من الصندوق الإقليمي المفتوح التابع لجيازات، ولكن أيضاً على أهمية مثل هذه التكنولوجيا في تعزيز التعاون عبر الحدود بين الأراضي الفلسطينية والأردن. كجزء من المؤتمر نظمنا جلسة مناقشة مفتوحة ستركز على مؤشرات الوضع الصحي في كل من الأراضي الفلسطينية والأردن، وإيجاد سبل للتغلب على التحديات والمشكلات. ويشرفنا أن يكون معالي وكيل وزارة الصحة الفلسطينية الدكتور عنان المصري، ومعالي المهندس وجيح عزيزة رئيس لجنة فلسطين في مجلس الأعيان ومدير عام دائرة الشؤون الفلسطينية سابقاً، والدكتور أمية خمش رئيس برامج صحية ميدانية من الأونروا، والمهندس أيمن الروابدة مدير برامج الرعاية الصحية من شركة سيسكو سيستمز، والدكتور جوني خوري رئيس استشاري لأمراض القلب من مركز الإغاثة الطبية والتشخيص في الأراضي الفلسطينية، جزء من الجلسة النقاشية. ونحن نتمنى الاستماع للمناقشة بين الخبراء المتميزين، ونعمل أن يتم عرض تطبيق الطب الاتصالي على جدول الأعمال الوطني التابع لوزارة الصحة في كل من الأراضي الفلسطينية والأردن. نحن سعداء أيضاً أن يكون معنا اليوم 2 من المتحدثين الدوليين الذين سيشاركوننا خبراتهم المختلفة مع الطب الاتصالي. ستكون المتحدثة الرئيسية الدكتورة تانيا براتان من ألمانيا للحديث عن تطور شبكات الطب الاتصالي في المملكة المتحدة وألمانيا، وسوف تناقش الدروس المستفادة من اعتماد مثل هذه التكنولوجيات في المجال الطبي. كما سيتحدث أيضاً الدكتور مهند العجلاني عن أبحاثه في اعتماد الطب الاتصالي في الأردن وكيف يمكن توسيع استخدامه في المنطقة. ونحن أيضاً محظوظون أن يكون معنا الدكتور محمد نجاج من مستشفى بيت جالة، والدكتور إياد سلطان من مركز الحسين للسرطان، وسوف يتحدثون عن خبراتهم في التشاور عبر الطب الاتصالي في حالة سرطان الأطفال. وسوف تكون هناك فرص لتبادل الأفكار الخاصة بكم حول الطب الاتصالي وطرق زيادة استخدام التطبيق في المستشفيات. ولهذا فإننا نتطلع إلى يوم مليء بالمعلومات. وفي الختام لا يسعني إلا أن أعبر عن شكري وتقديري العميق لفريقي الرائع الذي بذل مجهود كبير لنجاح هذا المؤتمر، وهو مكون من تالا اليوسف ولما نوران وكارولين بانوت. ونتمنى أن تستمتعوا بالمؤتمر وأشكركم جميعكم على مشاركتكم.
Thank you very much for your friendly introduction. Dear Deputy Minister of Health, dear ladies and gentlemen, I'm very happy to be here today. It's a great honor to present to you some lessons learned of telemedicine and eHealth in Germany and the UK. Unfortunately, I can't talk to you in Arabic because my Arabic is very poor, but I hope you can understand me in English or that the interpretation will be very good. I've chosen this picture because on the left you see how medicine used to be such a sort of solitary science, and now it's much more connected, much more interdisciplinary. People are sharing information, talking to other disciplines, and so, well, this is all for the benefit of the patient, for making healthcare safer and better. Just a little bit about myself. I work at the Fraunhofer Society, which is the largest society of applied research in Europe. I work in the south of Germany, in Karlsruhe. And our institute deals with innovations, all kinds of innovations really, but my focus is innovations in healthcare, which obviously includes telemedicine. And previously I've worked in the UK, I should probably mention that I've worked on an electronic patient record which was being introduced nationwide, and we're doing an evaluation of that. So today I'd like to give you some brief definitions of telemedicine and other related terms, just very brief because I'm sure you know all about it. Some trends that we've observed in society and in healthcare, and then describe the current situation in Germany and the UK, which is far from favorable still. And I'd like to talk about two case studies of telemedicine. One is Teleradiology in Germany, and the other one is telecardiology in the UK. Obviously, these are just two examples of the broad range of telemedicine applications. And then I'd like to talk about some lessons we've learned along the way and come up with some conclusions. So eHealth is sort of an umbrella term, basically, which includes all sorts of things, be it electronic patient records or hospital information systems, practice information systems, decision support systems, etc. And part of this is obviously as well telemedicine and telecare. So eHealth we would define as basically all healthcare being delivered with the help of information and communication technologies, and then telemedicine being medicine delivered over distances of space and time, and telecare, which is obviously not the focus of today, but I just like to bring it up because my main experience has been with telecare, and I think it's quite interesting and quite related. So this would be patients collecting data at home and then sending it across to healthcare professionals. So if someone has like a condition which would benefit from being monitored regularly, like heart failure, say, or chronic obstructive pulmonary disease, then they could send that data and be managed better. Yeah, so that's just the definitions here. Okay, in terms of the trends, in Europe we've seen some, and it's not just Europe, I'm sure we've seen some trends affecting the healthcare systems, that being more chronic diseases being prevalent, more mental health issues as well, the threat of rising healthcare costs, the patient having more influence in terms of being a consumer of healthcare as well, not just a sort of receiver. Staff shortage in some medical specialties and some, especially nursing as well, and the trend towards a more holistic approach to health. So not just treating individual conditions, but treating the whole patient. Then there's some political and societal trends, which is more mobility, more diverse, culturally more diverse, patient patient groups, the workforce being more diverse, demographic change, which in Europe is especially, of course, the aging population, and people having more individualized lifestyles, or wanting to have more individualized lifestyles, and not this one-size-fits-all sort of working for everyone. Plus, on the scientific and technological level, there's been, of course, in sort of what we call key enabling technologies like ICT, genomics research, nanotechnologies. There's been a lot of progress with diagnostics, with implants, for example, with personalized medicine. And so what's been happening there has had, of course, a huge impact on healthcare as well. And what this is doing really is that we're moving away from this very reactive healthcare system, which just reacts when somebody has gotten ill and when something has gotten wrong, to something which is more proactive and which helps people actually manage their health better and be much more preventative about it as well. So in terms of the scientific and industry players, there's new players now entering the industry, and of course they're going to shape it as well. In terms of the political and societal trends, we have a broader understanding of healthcare now, and also what role the individual can play in it. Right, okay, that's okay. Now, with this big green circle, what I wanted to show you is basically how eHealth can contribute to such a more advanced healthcare system. And we would have in the very inner circle, you would have the home being sort of the primary healthcare location, centering around the patient and centering around the support network that the patient has. And then in the second circle, it would be more the primary care setting, where we have the general practitioners. So that would be the family physician, other people call it. You would have pharmacies, you would have specialists, and in the outer circle would be university hospitals and very advanced medical settings that people wouldn't usually come into contact with, but it does happen, of course. And the idea is that all these people, that what you see in yellow here, I'm not sure if it shows very well, but that would basically be, you can't really see the difference between yellow and orange. Okay, I can just see that. But if you imagine the patient connecting with a specialist and the specialist connecting with other specialists, as well with the university hospital and general hospital, that can all be done via telemedicine. So that's the idea, and all that being supported by the electronic patient record, which helps to shift data across. And what this shows as well is that telemedicine does involve the patient, so it's not just something being talked about the patient, but also the patient being by the side of the clinician and them discussing that together with another clinician. Now, okay, that's a vision. Of course, we don't really have that yet. So the reality is more like that, like in the Middle East, I think. What we have in Germany and in the UK are mostly rather small local initiatives and mostly funded by research projects. In Germany, for example, there's been one project and it counted 272 eHealth projects. So that's quite a lot, but they're not part of mainstream healthcare. They're just small projects being funded by research, and once the funding has run out, they usually finish. And in the UK, the situation is quite similar. In terms of reimbursement, like I said, it's not part of mainstream healthcare, so these projects will not be reimbursed as regular healthcare. And in general, we can say there's a lack of awareness, of knowledge, of acceptance by everyone pretty much involved, although we can say that is growing bit by bit. Closely linked to this lack of acceptance and awareness is a lack of evidence and lack of consensus on what benefits telemedicine actually brings. Then, in terms of IT infrastructure in the UK, we have the infrastructure. It's called the N3 network. So whoever is connected to the N3 network, and that goes for pretty much all hospitals and general practitioner practices, they can connect with each other. So that's very good. Now in Germany, we don't have that yet. There's something being built at the moment, but we don't have this national IT infrastructure. And linked with that, obviously, is a lack of interoperability as well, because there's lots of different systems, and they might not be able to connect with each other. Then there's a lot of concerns around what happens if something goes wrong, if someone unauthorized accesses the data, if a wrong decision is made based on data transferred by telemedicine. So there's a lack of that being sort of really clear, and that hinders the adoption of telemedicine. We have fragmentation between the different healthcare sectors, so primary care, secondary care, and tertiary care, nursing, different professions, people still operating more or less on an individual level. On the positive side, we can say there's a good availability of technical solutions. The technology is more or less ready. And in terms of politics, there's a big push now as well, because the potential of telemedicine has been realized, and it is being pushed forward. And also, hospital clinicians have been found to be much more accepting of telemedicine than clinicians in their own practice. And I think that's because they're more used to collaborating anyway. That's more part of their job already. Then I'd like to briefly talk about these two examples of telemedicine. So we have teleradiology, which is a radiological examination carried out by a qualified technician in one side under the supervision of a radiologist in another side. And that is one way teleradiology can be carried out. There's a second way as well. So what is needed is, first of all, to be approved as a site for teleradiology. It can't be just carried out by any hospital. And what they need to be approved is to have the right equipment for carrying out the scans at the referring side, and the equipment for receiving the images and interpreting them at the receiving side. We need a qualified technician, and of course we need a radiologist at the other side. So if someone has, like say, a car accident during a weekend, and at the nearest hospital there isn't a radiologist on site, in that case they could use teleradiology. But the requirement is to only be done at weekends, evenings, and during the night. So it couldn't be done during the day. This is quite strictly regulated. And then so the technician at the ascending hospital could say what medical question they would like to be answered by the scan, send a request, and the radiologist would then agree with them what would need to be done. The scan would be carried out, sent across. The radiologist would interpret the data and send that back. And so the patient could then be treated at the sending hospital. Of course, this needs a good internet connection because it's kind of live. So this is the first scenario. The second scenario is much less regulated because it would basically be second opinion between two radiologists. And this would be done especially for difficult cases where perhaps it's not clear and the first radiologist would like to get some input from the second radiologist. And in Germany, this is often done in radiology networks, although, of course, in general, radiologists can connect with each other, but usually it's done in networks. And like I said before, these are research projects generally. Now, the advantages are that one radiologist can look after several hospitals, which is quite nice because it covers out-of-hours care, evenings, weekends, nights, etc. It's good for the radiologists as well because they don't have to do the unpopular shifts at nights and evenings, etc. It addresses a clinician shortage, which we have. Also, if someone goes on holiday, they don't need to have another person in. They can cover this through the radiology network. And for remote areas, because we have some quite underpopulated areas, it's nice because then the patient doesn't have to be transported and the results can just be sent across. So the main advantage really is better diagnostics for the second opinion, and for the first scenario is convenience for the clinician and for the patient. And teleradiology is a prime example of telemedicine in Germany because it's been around for a long time. It's been based on the DICOM standard, which was introduced quite early on. And I think it's the most advanced example, and a lot can be learned from it. Okay, now the second example, I wanted to show you a short video because I think that can show it much more nicely than I can. Oh, sorry, we've got it here already. Okay, let's see if this works. Just decline that. Yeah.
Just go to the Chrome box, it's already up.
Oh, sorry, okay.
It's here.
Perfect.
Really?
Okay, hello Mr. Green.
Good morning to you. Morning.
Now, how long have you had this ulcer for?
Mid to the end of March it started.
Right.
This treatment started early April.
And what's happened to it?
Of course, telemedicine in itself is nothing new, but as it's been developed here at Chorley Wood, it most certainly is. It's no longer confined to a long-distance consultation between patient and consultant in different locations using teleconferencing facilities.
Gradually getting better now.
Right. Is it very painful?
In essence, telemedicine calls for an entirely new approach to investigation and diagnosis, resulting in a change of responsibilities and consequently a change in the working relationship between the primary care team and hospital consultants and their staff. The man behind its development is the senior partner here, Dr. Russell Jones.
We're now talking about working differently, removing all the barriers between professional groups so that they can work together, become more efficient, do more things for the patient, particularly in the community before they get near the hospital.
I'm getting a very clear picture here, and it doesn't look as if you need to be referred to a consultant, which is the good news. Okay, that's a very nice picture there.
Okay, just relax your arm down now, and I'll do an office run, and this will give you an idea of what it feels like.
Just to get you to wear this now for 24 hours, then this time tomorrow if you just take it off and bring it back to the surgery.
If you boil it all down and you look at it and you decide what on earth is going on here, I think really what you're talking about is you're moving the clinical data, that clinical data that says this patient has or hasn't got this illness, you're moving that data about between decision makers in healthcare, and you aren't moving the patient around.
But in order for the GP to move the data, if that should prove necessary, the data, first of all, have to be collected. And that's where the real difference in approach between Chorley Wood and most GP practices, mine included, becomes apparent. Apart from the teleconferencing suite, this place is fitted out with all sorts of specialist equipment that you'd normally expect to see only in a hospital. And what's more, the staff, the GPs, nurses and physiotherapists who work here have been trained to use specific pieces of it. Between them, they carry out a whole range of tests that can assist in or confirm the diagnosis of some of the more prevalent diseases that normally require the intervention of a hospital specialist.
Did he have any symptoms when he was having the 24-hour take?
No.
And it's then, and only then, after the results have been analysed and following a referral, that the teleconferencing side of telemedicine comes into play.
Heather, are you happy with how it's going in terms of healing?
It seems to be doing really well. It was very, very deep, so it's come up quite nicely.
And surprisingly enough, that crucial element, the actual consultation, doesn't always involve the GP. That's because the usual hierarchical structure, which one would expect to see in a GP surgery, doesn't exist here. So, for example, the 3 specialist nurse practitioners share total responsibility for all the vascular patients. Sister Heather Francis is one of them.
It doesn't involve the GPs at all. We have learned how to assess refer, do the referral letters, do the workup, book in the date for the link and link with a consultant, which means that we actually have that interaction with the consultant where normally we wouldn't see them at all or know the outcome until a good few months down the line.
And not only is that an example of an excellent use of resource, it's also highly motivational. The major beneficiary of this approach, though, is undoubtedly the patient, and the major benefit is speed. Speed of both diagnosis and consultation. Alan Price Davis, who went to the...
All right, I'll just stop that there. Right, okay, so that was an example of telemedicine being carried out at a very innovative GP practice near London. And as you can see, they're doing all sorts of telemedicine. And as I said, it's very interesting because, well, the roles have changed. It's all for the benefit of the patient. And also nurses are taking on quite an important role, which is not usual, right? So to summarize the benefits of telemedicine, distances can be overcome. The patient does not need to be moved in many cases, and as a result, we have better treatment decisions and better clinical outcomes. And outcomes can be measured as, for example, less hospital admissions, shorter hospital stays, a whole range of clinical parameters, not even to mention morbidity, mortality, etc. Treatment can be more continuous because the referral doesn't take as long, ideally, as it would take usually. And learning and knowledge transfer takes place between the clinicians involved, so that's both ways. One thing that we've seen is, for example, when you have regular teleconsultations between clinicians, the questions that get asked change over time, and perhaps in some cases they wouldn't need the consultations anymore because they've learned something, and they would know how to deal with these cases already by themselves. Patients can become empowered, especially if they're there with the clinician, and the decisions that are being made together with the patient, and they have a role to say what they want. Job satisfaction for clinicians can increase because they might feel less isolated. There's more of a sense of doing a good job, doing the best that they can. And for example, in the case of the teleradiology, there's less need to do unpopular shifts where a lot of it might be just waiting around for things to happen. But what's important to remember also is that benefits may not always be measurable easily, they may not be immediate, they may emerge in the long term only, and initially there may be an increase in cost and in workload. So it's important to bear that in mind. And what we've learned along the way is basically that it's important to start with a small service, which is quite clearly defined, with a limited number of patients. And once that's running smoothly, then to add on to it. And to engage the clinicians that are supposed to be using telemedicine quite early on and develop it together with them, because otherwise they might feel that something is imposed on them, that they're being forced to do something, and it doesn't fit their ways of working. Then top management support within the hospital is important, because if things do go wrong, top management has the power to intervene, and it also sends out a positive message that this is something that is wanted at the hospital. Within the hospital, it's very good to have a favorable climate for trying something new, the allowance to make mistakes, because when new things are introduced, of course, there will be mistakes. So it's very important to have that kind of climate where you can try things. Then when you consult somebody else for their opinion, of course, there needs to be a level of trust, especially if you only see them over video or you don't see them at all. So it's quite good to actually have met face to face, and that you don't feel the sort of the threat of losing face if you ask them for their opinion. There needs to be time for getting used to the system, for learning how to use it, reflecting it, making it fit with your working processes. What's very helpful as well is having champions, so people who have influence to convince other users that this is something beneficial. And ultimately, of course, we need some kinds of incentives for adopting the telemedicine. Ideal are win-win situations where both parties benefit, but if there's sort of some kind of uneven distribution of benefits, then some sort of other incentives or some kind of compensation may be useful. In terms of the clinical lessons learned, the most important thing that we've learned is that there needs to be a clinical need addressed. It's basically not going to help anyone if the telemedicine doesn't match a need. And within that, identifying the right cases, because telemedicine is not the right treatment for every single patient, but we need to find those where it will make a difference. Technology needs to work. I mean, doctors are not technicians, and if the technology doesn't work, I think they're going to be very demotivated quite quickly. And if something goes wrong, they need to know who to contact, and it needs to be fixed quickly, otherwise they lose faith in the technology. I talked about the learning, and I think that's quite an important thing, that both sides learn something, and that's a very nice effect to observe. And finally, because there's such a lack of evidence at the moment still, so if there is a telemedicine project, it's very good to also evaluate, to demonstrate that it does make some difference. Now, of course, there are some things which are sort of too big to be addressed at the organizational level, and that needs political input. For example, the funding and reimbursement is very important on that level. The level of collaboration between different healthcare providers and different sectors in healthcare. In general, creating awareness of telemedicine and of the benefits it can offer, and then, of course, legal issues, liability, protecting patient privacy, etc. On the technical side, some standards need to be agreed on, and this is even bigger than on a national political level. This is an international issue. And back to the sort of national level, we need, or it would be ideal to have an IT infrastructure. It makes things a lot easier. Sorry, that was too quick. To conclude, healthcare is becoming much more connected and much more global. If we think of multinational clinical trials, if we think of biobanks, registers, etc., also the challenges that healthcare faces, like pandemics, chronic diseases, and it's becoming more specialized, just thinking about the new healthcare professions. And telemedicine will play a major role in healthcare becoming more connected and addressing these challenges that we're facing. But we have to remember it's not a miracle. It will only work as well as the sort of context in which it operates. So that's why the political level has a very important role to play in setting the right framework conditions. But I think innovative clinicians like yourselves can really play a major role in creating demand and shaping the development of this of telemedicine. So I think you have a really important role to play here. And thank you very much. Shukran.